You have a patient with rapidly progressive weakness. Reflexes are absent, CSF protein is high. If your brain immediately screams GBS, congratulations. If it panics and starts mixing myasthenia, spinal cord compression, and hypokalemia together, stay with me. By the end of this video, Guillain-Barré syndrome will be structured, logical, and easy to recall in exams and wards. Guillain-Barré syndrome is an acute, immune-mediated inflammatory polyradiculoneuropathy. Acute meaning progression over days to weeks. Immune-mediated meaning antibodies are involved. Polyradiculoneuropathy meaning multiple nerve roots and peripheral nerves are affected. This single line already earns marks if written properly. Imagine peripheral nerves as insulated electrical cables. In GBS, the immune system mistakenly attacks the myelin sheath in demyelinating forms, the axon itself in axonal variants. This happens due to molecular mimicry, where antibodies formed after infection cross-react with nerve gangliosides. So weakness is not muscle disease, it is a signal transmission failure. Around 2/3 of patients report a preceding infection 1 to 3 weeks earlier. Common associations: Campylobacter jejuni, CMV, EBV, Mycoplasma pneumonia. In exams, always mention Campylobacter first. If diarrhea appears in the stem, your probability score just doubled. GBS typically presents with symmetrical limb weakness, ascending pattern, loss of deep tendon reflexes. Weakness starts distally in the legs and progresses proximally. Sensory symptoms exist but are mild compared to motor involvement. If sensation is dramatic, think twice. Progression occurs over days to weeks, reaches nadir within 4 weeks. After that, plateau phase, then recovery. GBS does not keep worsening for months. If it does, think of CIDP. Examiners love this distinction. Cranial nerve involvement is common. Facial nerve palsy is most frequent. Bulbar weakness may cause dysphagia, dysarthria. This is clinically important because aspiration risk increases. GBS patients may look stable until they suddenly are not. Autonomic instability is a key cause of mortality. Features include tachycardia or bradycardia, blood pressure fluctuations, arrhythmias. This is why ECG monitoring is essential. GBS is neurologically quiet but physiologically unpredictable. Up to 30% of patients may require ventilation. Monitor vital capacity, single breath count, use of accessory muscles. Do not wait for cyanosis. In GBS, respiratory failure can be silent until late. Variants include AIDP, most common in Europe and Sri Lanka, primarily demyelinating, AMAN, pure motor involvement, often post-Campylobacter infection, AMSAN, motor and sensory axonal damage, poorer prognosis, Miller-Fisher syndrome, triad, ophthalmoplegia, ataxia, areflexia. Anti-GQ1D antibodies are characteristic. Classic CSF finding is albumin cytological dissociation, meaning raised protein, normal or low white cell count. Important exam point: CSF protein may be normal in the first week. Never rule out GBS early based on CSF alone. NCS helps confirm diagnosis, differentiate demyelinating versus axonal forms. Demyelinating, slowed conduction velocity, prolonged distal latencies. Axonal, reduced amplitude. Mentioning this scores extra marks. GBS is a medical emergency. Admit all patients. Disease-modifying therapy, IVIG, plasma exchange, Both are equally effective. Steroids are not beneficial. Supportive care includes DVT prophylaxis, physiotherapy, pain management. Most patients recover over weeks to months. Mortality is around 5%. Poor prognostic indicators, older age, rapid progression, ventilator requirement, axonal variance. Recovery is often excellent with early care. If asked to summarize GBS, acute onset symmetrical ascending weakness with areflexia following infection due to immune-mediated peripheral nerve damage, diagnosed by raised CSF protein and treated with IVIG or plasma exchange. Write this and breathe. If this explanation helped you finally organize GBS in your head, subscribe. This channel exists to make textbooks understandable and exams less cruel. Next video will break down another high-yield neurology topic the same way.